95% of women. Recording in progress.
Take it back to the first page. Like step there.
Don't worry, we haven't let the other members of the audience in. So we will let everyone in at 13:05. IT, can we please see the team on camera? Just so they have an idea of what they look like. Presenters, how do we feel? Their mic is off. Can you please turn on the mic for me? Presenters, can we please unmute our mics?
Yes, you know, I'm mentioning the participants now, then we'll start at 18:05.
Okay, before you let them in, can we just quickly hear how the how the presenter sung? Presenters, can you say something?
Good afternoon, everyone.
Okay, great. The sound is good. Okay. So don't forget to project your voices. All right. Mr. Zulu will let everyone in.
Okay, I'm letting them in now.
Good afternoon, everyone, and welcome back to our virtual presentations. These are our preclinical presentations. I would like to welcome everyone back. Now, today's topic is understanding the concept and practice of assisted reproductive technologies, a mitigating factor towards infertility profile in Zambia. I'm your host, Ms. Shinondo, and I will be one of your moderators, particularly for question and answer. These are presentations for our students by our students. These are presentations geared towards skill set building within our students. Skills such as long case presentation, public speaking, self-presentation, critical thinking, and more. This is a chance for them to get hands-on experience, especially with dealing with online etiquette, webinars, seminars, and the like. This is also an excellent opportunity for those of you in attendance, especially our students, to seize this opportunity to engage. You too will learn how to speak online through the question and answer session. This is a learning experience for both students in front and behind the camera. I would like to acknowledge the presence of our professorial team, Professor Lambert, Professor Njelesani, Professor Modenda, Professor Mwaba, Professor Emaus, Professor Mwansa, Professor Mulenga, as well as Professor Kasonka, Professor Kasolo, Professor Kumar, and Professor Gilani, to name a few. I would like to invite our moderators, Professor Eta and Professor Oberton, to briefly introduce the topic and begin the presentation. Moderators, the floor is yours.
Thank you, Madam Moderator. I want to welcome all of us to this very exciting topic today. Appreciation goes to the management of APEX, who have made this program very exciting and have given us the support. I also want to acknowledge the presence of our viewers, especially professors across different. We want to thank you for always keeping faith with us. Today is going to be an interesting discourse. Infertility has become an international and global sport. And so we are narrowing down on how we who are in Zambia can help to mitigate the rising indices of infertility by trying to interrogate and make use of certain techniques that are available. Our presenters, second year students, will do great justice to this. They sit down and relax while they take up the video. Thank you very much.
Good afternoon, panel, professors, colleagues. Ladies and gentlemen, my name is Virginia Tandakanyoka, a second-year medical student at Lusaka Apex Medical University in the Faculty of Medicine and Surgery. I will be giving an introduction to today's ground runs, which will be on a topic of understanding the concepts and practice of assisted reproductive technologies, a mitigating factor towards infertility in Zambia. So picture this. There comes a time in our lives when we want to become parents, but then we are unable to due to factors out of our control like genetics. This is a growing problem in our country, which is known as infertility. How do we define infertility? Infertility is defined as the inability to conceive a child in a year or more of having unprotected sexual intercourse. Infertility is known in two types. We have primary infertility, where one is unable to conceive at all, and secondary infertility, where one is unable to conceive after one pregnancy or another. So this is a growing problem. that is affecting people on different aspects. It affects people on a personal aspect in a way that one might suffer from depression due to feeling the lack of accomplishment or lack of legacy, knowing that they won't have anyone to take over their name. It also affects people on a social aspect because it brings in stigma and discrimination from the community and the society. Family members are likely to say things about one who does not have children. On the economical aspect, some people might not respect you in your area of work. Let's say, for instance, if there was one family man at your workplace that needed a raise and one that does not have a child that needed a raise, your company is likely to favor one that has a family, considering that they have more responsibilities compared to one that does not have. This might bring about a feeling of feeling less than in one person's life. As we speak of today as it stands in Zambia, the statistics of infertility are as follows. We have 38.5% of women experiencing primary infertility and 61.5% of women experiencing secondary infertility. These numbers, as shown in the chart, explain just how much this is a problem in our community. Had it been in the 1950s, this problem would have persisted. But since medicine has advanced, parenthood is now possible, all thanks to assisted reproductive technologies. So what is assisted reproductive technologies? You might be wondering. Assisted reproductive technologies, these are medical procedures that are used to treat infertility. These technologies have revolutionized the field of reproductive medicine by providing options for couples who are unable to conceive naturally. And these examples are as follows. We have in vitro fertilization, gametes intrafallopian transfer, zygote intrafallopian transfer, frozen embryo transfer, cryopreservation, and intracytoplasmic sperm injection. At this moment, allow me to welcome my colleagues who are going to take this discussion later. Thank you.
Good afternoon, ladies and gentlemen. My name is Buletu Silodemi Chwayo, a second-year medical student at Lusaka Apex Medical University. I am here to speak about in vitro fertilization and embryo transfer. So in vitro fertilization is a technique whereby the egg and sperm are allowed to fertilize outside the human body in a laboratory dish, while embryo transfer involves the process of placing the resulting embryos into the uterus to establish the pregnancy. One may wonder how this process takes place. Well, it all begins with ovarian stimulation and monitoring, whereby fertility medications are administered to the patient to stimulate the ovaries to produce multiple follicles which contain eggs. So once the follicles have reached a certain size, a non-invasive medical procedure is performed to retrieve the eggs from the ovaries using a needle guided by an ultrasound. A semen sample is then collected and to isolate healthy and motile sperm in preparation for fertilization. The retrieved eggs and prepared sperm are then allowed to fertilize in a laboratory dish, and in some cases, intracytoplasmic sperm injection may be used, where a single sperm is directly injected into each egg. The fertilized eggs are then cultured in closely monitored conditions to allow for cell division and growth to occur. So after a few days, the most viable embryos are then selected for transfer. A thin, flexible catheter is gently used to place the embryos into the uterus via the cervix without the need of anesthesia. The patient is then advised to rest and follow post-transfer instructions, and after approximately 2 weeks of the embryo transfer, A blood test for human chorionic gonadotropin hormone is done to see if pregnancy has been achieved. As we can see, this is a diagram illustrating the processes, the steps I have just mentioned above. Allow me to dive into the indications of IVF. IVF can be considered in cases whereby the cause of infertility is blocked or damaged fallopian tubes, simply because the IVF process bypasses the tubes, allowing fertilization to occur outside the human body instead of them. In cases of male infertility, such as low sperm count, poor motility, and abnormal morphology. In cases where there is no cause of infertility that can be identified. At times, women with ovulation disorders, such as irregular ovulation and anovulation, or conditions like endometriosis, which is simply when tissue grows outside of the uterus, they can also consider IVF. Couples who have had previously failed fertility treatments, such as intrauterine insemination, can also consider IVF. Allow me to dwell into the advantages of IVF. IVF has a high success rate compared to other fertility treatments. It allows one to have control over the number of embryos, therefore reducing the risk of multiple pregnancies. It brings about an opportunity for genetic testing to identify potential genetic disorders and avoid passing them on. Most importantly, IVF brings about emotional fulfillment as it helps couples achieve their dream of having children. Now, I would like to call upon my next colleague to continue the presentation.
Good afternoon, ladies and gentlemen. My name is Agatha Mazibuko, a second-year medical student at Lusaka Apex Medical University. And today I'll be here presenting on the gamete intrafallopian transfer. What is the gamete intrafallopian transfer, if you may wonder? This is a procedure that involves the direct placement of the egg and the sperm inside the woman's fallopian tube in order to facilitate fertilization inside the body. Now moving on to the procedures of the gamete intrafallopian transfer. Firstly, we have ovarian stimulation and monitoring. Similar to the in vitro fertilization, medications are used to stimulate the ovaries to produce multiple follicles containing eggs. Regular ultrasounds and blood tests help to monitor the growth of these follicles and hormone levels. But we have to keep in mind that specific medications and dosages will depend on individual factors, such as age, quality of the egg, quality of the sperm, and other individual factors that I have to mention. Secondly, we have egg retrieval, which is a minor surgical procedure that is performed to retrieve the eggs from the ovaries using a needle guided by the ultrasound. In this case, the ultrasound is used to have proper visualization of the placement of the ovaries and the surrounding tissues. Now moving on to sperm preparation. A semen sample is collected to process healthy and motile sperms for fertilization. Fourthly, we have the gamete transfer. Using a laparoscope, a thin tube with a camera and a light. The retrieved eggs and prepared sperms are placed direct into the woman's fallopian tube. This allows fertilization to occur inside the body, similar to natural conception. Then lastly, on our procedures, we have post-transfer care and pregnancy tests. The patient is advised to rest and follow post-transfer instructions approximately 2 weeks after gamete transfer. The blood test is performed to detect the presence of human chorionic gonadotropin and determine if pregnancy has been achieved. The presence of this hormone suggests that implantation has been successfully achieved. As you can see, this is an illustration of the procedures that are followed in the gamete intrafallopian transfer. Okay. When can one undergo the gamete intrafallopian transfer. When one of the two fallopian tubes should be functional for this procedure to be successfully achieved. It is used in cases where a female is unable to produce an egg, but is able to continue with fertilization and pregnancy. It is also used in cases of mild male infertility. It is not in virtual fertilization because fertilization takes place inside the body. Unlike in virtual fertilization, where the fertilization is achieved on a laboratory dish. It requires laparoscopy to put the egg back, hence it is semi-invasive. The success rates for this procedure vary from one individual to another, but on an average, we have 25 to 30% success rates. And this mainly depends on the age of the couple, quality of the ovum, and the sperm. With the advent of the in vitro fertilization, the gamete intrafallopian transfer is used less as the IVF success rate is good. It does not require laparoscopy. Other assisted reproductive techniques, such as the ZIFT, which is the zygote intrafallopian transfer, the embryo transfer, which is also known as the ET, and the intracytoplasmic sperm injection, which is also known as the ICSI. Now moving on to the advantages and disadvantages of the gamete intrafallopian transfer. Starting off with the merits of this procedure, it is similar to natural fertilization, as fertilization occurs in the natural environment of the fallopian tube. It is ethically considered, where other individuals are a bit not so okay with having to mimic or having to have other procedures where they have to create or manipulate embryos outside the body. It is an alternative use to the IVF, can be used when other ART methods are not suitable or have failed. Now moving on to the disadvantages of the gamete intrafallopian transfer. It is not suitable for women who have tubal damages with blockages. If tubal damages have been found, this procedure cannot occur successfully. It can have multiple pregnancies. Transferring multiple eggs increases the risk of twins or higher order multiples. It has high risks of ectopic pregnancy. A small risk exists for the fertilized egg to implant in the fallopian tube instead of the uterus. Now moving on to the surgical risks of this procedure. Laparoscopy requires for gamete transfer, carries risks such as infections or bleeding. Unlike the IVF, where fertilization can be confirmed before transfer, the gamete intrafallopian transfer does not guarantee fertilization, since it occurs inside the body. Thank you so much for your time and attentiveness. I'll now be passing on the floor to the next speaker.
Good afternoon, ladies and gentlemen. My name is Gordon Ndogo, a second-year student of Lusaka Apex Medical University. I'll be presenting on zygote intrafallopian transfer. Zygote intrafallopian transfer combines the elements of in vitro fertilization and gamete intrafallopian transfer to achieve pregnancy. Below are the procedures that are considered when doing this process. The first one is ovarian stimulation and monitoring. Similar to IVF and GIFT, fertility medications are used to stimulate ovaries, which then produce multiple follicles containing eggs. Regular ultrasound scans and blood tests monitor follicle growth and hormone levels. The second step is egg retrieval and fertilization. A non-invasive procedure retrieves eggs from the ovaries, which are then combined with semen in a laboratory dish to facilitate fertilization. The fertilized eggs are now called a zygote. The third stage is zygote transfer. Using a laparoscope, a thin tube with a camera and light, The zygotes are placed directly into the woman's fallopian tube within 24 hours of fertilization. This allows the early embryo to continue its development and implantation within the woman's body. The last stage is post-transfer care and pregnancy test. The patient is advised to rest and follow post-transfer instructions. Approximately 2 weeks after the zygote transfer, a blood test is performed to detect the presence of human chorionic gonadotropin and determine if pregnancy has been achieved. The diagram shows all the stages that I have been explaining about. Let's take a look at the indications for zygote intrafallopian transfer. Zygote intrafallopian transfer is typically considered in cases where other infertility treatments are not successful or not suitable, including unexplained infertility, male factor infertility, this is whereby the male partner has issues such as low sperm count, poor sperm motility. We've got ovulatory disorders whereby the woman has got difficulties in ovulation. Then we've got previous ART failures, couples who have failed cycles of in vitro fertilization. Then let's take a look at the conditions for patient eligibility. The first one is age. Women under the age of 35 generally have got better success rates, although zygote intrafallopian transfer can be performed on older women with healthy eggs. And if that's not the case, then the donor eggs may be found useful. Then the second one is functional fallopian tubes. At least one fallopian tube must be functional or must be open and healthy, is determined by diagnostic tests such as the laparoscopy. Healthy uterus, the uterus must be capable of supporting pregnancy. Any uterine abnormalities such as fibroids should be addressed before the procedure. Then the next one is sperm quality. The male partner should provide sperms that can successfully fertilize the egg. If that's not the case, then donor eggs may be found useful. Then the other factor is egg retrieval capability. The woman must be able to undergo ovarian stimulation and egg retrieval. Then the last day that we have is general healthy. Both partners must be in good overall health to reduce risks during the procedure and pregnancy. Let's take a look at some of the advantages and disadvantages of zygote intrafallopian transfer. The first advantage that we have there is that it allows the embryo to develop in a more natural environment, which is the fallopian tube. Second advantage that we have, it has got higher success rates compared to gamete intrafallopian transfer, as fertilization is confirmed before the transfer. Let's take a look at some of the disadvantages. The higher risk of multiple pregnancies due to multiple zygotes being transferred. Then the last disadvantage that we have, the higher risk of ectopic pregnancies compared to in vitro fertilization, because the zygotes are being transferred directly into the fallopian tubes, such that implantation can happen in those fallopian tubes, which is the ectopic pregnancy. With this, I thank you. I'll call upon the next presenter.
Good afternoon. My name is Ahmed Koya. I'm a second-year medical student at the Lusaka Apex Medical University, and I'm here to present frozen embryo transfer. Now, simply put, frozen embryo transfer is a process of using previously frozen embryos and implanting them into the uterus of a woman to allow for pregnancy to occur. And it takes place in 6 main steps. The first step is to use fertility medications to allow the stimulation of the ovaries to produce follicles that contain eggs. And once these eggs are produced, they are retrieved using a non-invasive surgical procedure. After this, the retrieved eggs are then combined with sperm in a lab dish to allow for fertilization to occur. And then they are closely monitored to make sure that there is proper cell growth and cell division. Once the embryos have been fertilized, the ones that have not been used in a fresh in vitro fertilization cycle are then frozen for future use. And this can be done for various reasons, such as preventing the onset of ovarian hyperstimulation syndrome, which is simply an exaggerated response of the ovaries to the fertility medications. Or it can be done for personal or medical reasons. Now, once the embryos have been frozen, the endometrium, which is the uterine lining, must be prepared adequately to support implantation. And this is typically achieved through hormone supplementation, either through a natural cycle or an artificial cycle, or through ovulation induction. Now, once the endometrium, which is the uterine lining, is prepared, a thin and flexible catheter is used to insert the embryo into the uterine lining, and this is done generally without anesthetics. After this, there is post-transfer care and a pregnancy test, where the patient will be advised to rest and follow post-transfer instructions. And after approximately 2 weeks, a test will be performed to detect the presence of human chorionic gonadotropin, which will determine whether or not pregnancy has been a success. Now, if you turn your attention to the diagram that is being projected, you'll see a diagram showing the process that I have just overlined, except this one is slightly more summarized. Now, there are a variety of scenarios where frozen embryo transfer can be used. For example, if during an IVF cycle an excess amount of embryos are produced, the excess can be stored later and used at a later date. And embryo transfer may be delayed either because the uterine lining is not adequately prepared, or perhaps due to medical reasons or personal reasons, people would like to delay the pregnancy. Also, if the embryos are frozen, they can be genetically tested to test for any genetic abnormalities. And the embryos that have been frozen can be used in subsequent pregnancies, which has the advantage of not having to stimulate the ovaries once again. Now, the advantages of frozen embryo transfer include improved pregnancy rates due to the fact that the vitrification of the embryos allows them to have a higher chance of living. And this leads to higher chance of pregnancy, which leads to live birth rates. It also reduces the risk of ovarian hyperstimulation syndrome, which I have mentioned previously, is simply an exaggerated response to the hormones that are being used to stimulate the ovaries. It also has the advantage of being flexible in terms of time. That is, the patient can choose what time they would like to have the transfer done, and they may delay it due to personal reasons, medical reasons, or any other reasons. And frozen embryo transfer is also generally less expensive than a full in vitro fertilization cycle, due to the fact that the embryos that are being used have already been collected and stored. However, it is not without its risks and challenges. For example, there is a risk of multiple pregnancies due to the fact that many embryos are being transported at once. And there's also a very rare chance of ectopic pregnancy. And despite the high success rates, there is a chance that some of the embryos will not survive the freezing and thawing process. And although it is less expensive than an in vitro fertilization cycle, it will still incur costs for thawing, storage, and transfer. Thank you for your attention. I would like to call upon my colleague to continue the presentation.
Good afternoon. My name is Ali Nabi, a second year medical student at X Medical University. I'm presenting on cryopreservation and intracytoplasmic stem injection. So I'll start with cryopreservation. Cryopreservation, this is a process of cooling and storing cells, tissues, and organs at extremely low temperature, usually in liquid nitrogen, at -186 degrees Celsius, in order to maintain the viability and the function of the tissues for future use. So the tissues, they are always kept at -186 degrees Celsius in order to stop the biochemical reactions that can occur in the tissues or the cells. Let us now move on to the procedure. So for the procedure of cryopreservation, we have two main procedures. The first one is slow freezing, and the second one is vitrification. So for slow freezing, this is a procedure where we gradually reduce the temperature of the material that we want to preserve. While vitrification, this is a procedure where we rapidly reduce the temperature of the material that we want to preserve in order to prevent the formation of ice crystals that can damage the material that we want to preserve. So by the use of these techniques, it can enable us to do oocyte preservation, which is the preservation of an egg or an ovum for future use. So for women who are about to undergo chemotherapy treatment, they can be able to undergo this type of treatment. It can also help us for sperm cryopreservation, which is preservation of sperm. So this one, it can be done in those men who are about to undergo chemotherapy treatment, and also those ones who are about to undergo surgical treatment like vasectomy. And it can also help us to do embryo preservation. So during some procedures like in vitro fertilization, if you have excess embryos, you can keep some of them for future use by freezing them. And by virtue of us doing these procedures, it can enable us to keep these materials for future use. As you can see on this diagram, it's illustrating the two main procedures of cryopreservation, which are slow freezing and vitrification. Let us now look onto the application of cryopreservation. So cryopreservation is very important in our today's world because it can help us to preserve some embryos, some oocyte, some sperms, even tissues from the ovaries and testes can be preserved for future use. And as we are doing this procedure, sometimes we might face some risks or challenges. So here are some of the risks and challenges of cryopreservation. The first one is cryoprotectant toxicity. So we use some agents called cryoprotectant agents. For example, we have dimethyl sulfoxide, even agents like glycerol. So if we add a lot of these agents, they can cause damage to these tissues that we are preserving. Second, we can have ice formation. So as we are using some procedures, for instance, if we are doing slow freezing, we can form some ice crystals that can damage the material. And thirdly, we have thermal damage. So for thermal damage, this is a damage that can occur as we are heating up the frozen materials so that they can be reused for the experiment. And sometimes it may be a cost for us to be able to store these materials. All right, let us now move on to the intracytoplasmic sperm injection. So for intracytoplasmic sperm injection, this is an assisted reproductive technique that is usually conducted when there is failure of in vitro fertilization. So for intracytoplasmic sperm injection, it has a couple of things that we need to put into consideration. So let us now move on to the procedure of intracytoplasmic sperm injection. For the procedure of intracytoplasmic sperm injection, we have 7 steps. So let's start with the first step. So the first step is sperm preparation. So for us to be able to do sperm preparation, first of all, we need to have semen samples. So we tell our client to go and bring semen by means of masturbating, or we can surgically retrieve those samples by using of surgical procedures like testicular sperm extraction or even percutaneous epididymal sperm aspiration. Then after we extract these sperms, we need to do sperm evaluation to ensure that we collect sperm with good quality. The second step is egg retrieval, where we need to retrieve the egg from the ovaries. So we give drugs like chloromethane citrate that can stimulate the ovaries to release some eggs. After we retrieve some eggs, we need to do egg evaluation, where we need to choose the egg with good quality. Then the fourth step is sperm injection. So for sperm injection, this is where now we get a sperm and we inject direct into the cytoplasm of an oocyte. So for us to be able to do this step, we need a micropipette, which is a small needle, and we use it to inject the sperm into the cytoplasm of an oocyte. And this procedure is done under a high-powered microscope by a skilled embryologist. Then the fifth step is fertilization and embryo culture. So the egg that was being fertilized needs to be incubated so that we allow differentiation to take place. Then after doing incubation, we also need to do embryo transfer, where we transfer that fertilized egg into the uterus. So for us to be able to do so, we need a small, thin, flexible catheter that is being inserted for us to be able to push that fertilized egg into the uterus. Then lastly, we have post-transfer care and pregnancy test. So for post-transfer care and pregnancy test, this is where we tell the woman to inject some rest and wait for at least 2 weeks so that we can do a pregnancy test in order for us to check for human chorionic gonadotropin hormone, which is a pregnancy hormone that can be detected via urine or blood for us to be certain to say the implantation was done well. So as you can see on this image, it's illustrating the procedure of intracytoplasmic sperm injection. Let us now move on to the indication for intracytoplasmic sperm injection. So for the indication, the first indication is male factor infertility. So there can be infertility that can disturb the male gender. For instance, we can have low sperm count, poor sperm motility, poor sperm morphology, as well as azoospermia, which can be obstructive and non-obstructive azoospermia. Apart from that, we can also have previous fertilization failure with in vitro fertilization, use of surgically retrieved sperm, use of cryopreserved sperm, even pre-implantation genetics testing, and unexplained infertility. So when we say unexplained infertility, we mean the infertility issues that are due to idiopathic or without a proper cause. Let's now go through the advantages of intracytoplasmic sperm injection. So intracytoplasmic sperm injection is very important in our today's world because it can allow us to do fertilization even with compromised sperm quality or quantity. Secondly, it can facilitate the use of surgically retrieved or cryopreserved sperm. Thirdly, provide an option for couples who have experienced repeated IVF failure. And as we are doing this procedure, we might face some challenges or risks. So here are some of the risks or challenges of intracytoplasmic sperm injection. The first one is egg damage. So the egg can be damaged as we are doing microsperm injection. Second, we can have fertilization failure due to defected quality of a sperm or an oocyte. Third, we can have embryo quality being compromised due to genetic abnormalities that can be passed using the same procedure. For example, you can have genetic abnormalities like Down syndrome, Patau syndrome, Edward syndrome. And according to studies, it shows that there is slight increase of genetic abnormalities in children who are conceived via intracytoplasmic sperm injection, especially in severe cases of male infertility. Let us now look on to the ethical consideration of intracytoplasmic sperm injection. So as we are doing this procedure, we have some ethical concern over the same procedures. The first one is genetic integrity. This is the ethical concern about the genetic abnormalities or defect that can be passed on using the same procedure. And secondly, we have embryo handling. So there are some ethical concern about the manipulation that tends to occur in the lab with the embryo handling. And in our today's world, we find that this intracytoplasmic sperm injection is very important because it is now representing a groundbreaking advancement in reproductive health, which has given a chance to those couples facing infertility challenges for them to have a chance to have children. So at this time, I'll call upon the next presenter to give us the summary on the conclusion.
Good afternoon once more. To round off, the issue of infertility was highlighted particularly in Zambia, where high numbers of women are facing primary and secondary infertility. We have noticed that secondary infertility was more prevalent, being 61.5%. It is a public health issue that needs to be addressed, as it may lead to issues of experienced aging populations. Assisted reproductive technologies offer a promising solution to these problems. Techniques such as in vitro fertilization, gamete intrafallopian transfer, zygote intrafallopian transfer, frozen embryo transfer, cryopreservation, and intracytoplasmic sperm injections that my colleagues had discussed in their own. As we have seen, each method plays a unique role in addressing specific reproductive challenges faced by individuals or couples who are wishing to conceive. Hence, the possibility for conception and parenthood is now possible. As we continue to advance and refine assisted reproductive technologies, it is essential to ensure that these technologies are accessible to those in need. Addressing infertility with compassion and comprehensive medical support can significantly improve the quality of life for affected individuals and their families. Our way forward is Shivani, a leading international company that manufactures artificial reproductive technologies and facilitates training for embryologists and fertility doctors, has recently sent a delegation to Lusaka Apex Medical University to discuss the way of establishing the first modular lab in Zambia. Thank you.
Excellent. Job well done, presenters team. Job well done. Without any further ado, question and answer session is now open. You can ask a question by raising your hand. The floor will be given to you and you can interact directly with our team of presenters, or you can write your comment in the chat and it will be read out for you.
Madam Shimondo.
Yes, Professor.
Madam Shimondo, I first of all appreciate the international participation in these topics. We have Dr. Peter, Associate Professor, Dean, Faculty of Basic Medical Sciences, University of Cross River State, Nigeria, is participating. Dr. Oria, Head of Department Anatomy, Faculty of Basic Medical Sciences, University of Cross River State, Nigeria, and Mr. James Ikapa, Department of Anatomy, University of Cross River State, Nigeria, and Dr. Michael Odi, toxicologist, Kampala International University, Tanzania, and Fefa Besi, a graduate of physiology from University of Cross River State, serving at the Odo State National Medical Center as a National Youth Service Corps member. So all these are from outside. I'm very grateful that they are participating, and we will continue increasing the professorial team, local and abroad. So can we clap for this?
Excellent. Thank you, Professor Lambert. However, I would like to note that it's quite unfortunate for those of us online, the noise cancelling. So we can't hear the applause, but we can see it. Now, once again, question and answer. The floor is open. Please take note, this is a learning platform for everyone, not only our presenters, but also those of you in attendance. This is your chance to get comfortable with online etiquette, webinars, seminars, and the like. This is a chance for you to learn how to ask your questions, how to phrase them, and how to interact. It's also a chance for you to get acquainted with Zoom. So please, do we have any questions? We have a round of applause twice from Mutemba. So we have a question from Chichi. What is the guarantee that the ICSI method will be effective in ensuring pregnancy?
Thank you very much for the question that has been asked. So the ISI is very important in our today's world because with intracytoplasmic sperm injection, there is no need to look for sperm quality or quantity. So it just requires one sperm to be injected into the cytoplasm there now to initiate the process of fertilization. Thank you.
Excellent. Well done. Dr. Oria, you have your hand up. The floor is yours.
Okay. Good day, everyone. Can you hear me?
Yeah.
Okay. Yes. So I'm not new to the grand rounds here. It's always a pleasure joining in and seeing how the students wow us with their wonderful presentation. This topic is very important because infertility is fast becoming a big global burden, and so the age of alternatives. So it's a nice one. I really appreciate their presentation. However, there is one aspect I would like the cost implication of these techniques or this technology. You know, we are in the low and middle income countries, so are these technologies accessible to people that are living in this part of the world?
Dr. Oria,
You know, or are there policies of able to bridge the gap in terms of finance so that people will be able to access and make good use of. Yes, please.
thank you, Dr. Oria. Could you please repeat your last
Did
sentence?
you get my question?
Could you please repeat your last sentence? The connection was a bit shaky.
Okay, but can you hear me now?
Unfortunately, the connection is quite bad. If you could please type it in the chat so that we can all get your question. Apologies for the connectivity challenge. We have a hand up from Dr. Jean.
Can you hear me now?
A bit, but it's not clear. If we can use the chat for your question. I see we have another hand from Dr. Jean. The floor is yours.
Yes. All right. Thank you very much, Ms. Shinondo. I hope I pronounced that correctly.
Yes.
Good afternoon. Permit me to greet my time. Good afternoon, Professor Lambert. Good afternoon, my brothers and colleagues over there, Professor Eta, Professor Batin. Good afternoon, colleagues online. And a very good afternoon to the students. You have done amazingly well. I sincerely appreciate your institution for this very topical presentation. Of course, like Dr. Oria said before the network decided to take advantage of him, the topic of infertility is becoming a global burden. So it's supposed to begin to give us concern as scientists. So it's a very good thing that you've chosen to raise this awareness through this presentation. Now, I would want to throw just two questions at the students. From the different technologies they presented, you see that there was one recurring test well, and that was that after 2 weeks, the patient will have to undergo a test. And they kept mentioning HCG, human chorionic gonadotropin. So I want to ask them, why this hormone? Why this hormone in particular? Why not any other hormone? And then the second question I have for them is, okay, being Africans, we have a lot to do with culture. So, and in choosing this topic, I think they would also somehow be interested in raising awareness for Africans. So, how do we handle cultural considerations? As Africans, we have to do a lot with culture. So, how do we handle cultural considerations? Thank you very much for this opportunity. I yield my mic.
So the question regarding the HCG, which is the human chorionic gonadotropin, we had mentioned that is the thing that is being detected after 2 weeks of the implantation. And the reason we're using a test to detect HCG is because when pregnancy occurs, HCG is released in large amounts. So if we're able to detect its presence, it means that the implantation has been successful. And I hope that answered your question.
Great. Yes, you did. Thank you.
And
Excellent.
regarding
Please continue.
Regarding the cultural implications, because these are emerging technologies, it might take some time for people to accept it in their culture. And it is not traditional, and some people do have ethical concerns. But I'm sure as it becomes more normalized, as these ARTs become more normalized, it will be assimilated into the cultures.
Excellent. Thank you. We have a question in the chat from Gladys. Is there a method suitable for those who have reached menopause to conceive? Or once they have reached menopause, none of these mentioned methods can work for them?
Thank you so much for that question. Earlier on, my colleague did explain that there will be need of donor eggs. Because when we are talking about menopause, we simply are talking about lack of eggs. That means the in the ovaries, they would have finished from ovulation. So you will need a donor's egg to be given for these methods to be possible. Thank you.
Thank you. Please feel free to use the chat. If we have any other questions, now is the time. Please remember there are no right or wrong questions. Your questions open more doors to a further discussion. I would also like to invite members of our professorial team who are present with us. I understand we have Professor Lambert with us.
Let me comment a bit. Thank you very much for allowing us to speak. But the questions, I'm sure they're still preparing the question. I think in the future, let a topic like this, so important, let's start our grand round at 12 hours so that we have enough time. You can see that the time is very much squeezed, and I'm requesting the registrar to give us extra time, maybe another 30 minutes, so that people can exhaust. Now, looking at the way the presenters have done, I say thank you very much. I think they are speaking with confidence, clarity. It's beautiful to listen to it. And it is so good that we have reached this level. Professors Obiten and Professor Eta, please, that's the spirit. Let's maintain the standard. Now, when I was their age, 1971, we are doing first year university, natural sciences and that. Professor Maya was teaching us biology, and he said to us, 20 years from now, men will become irrelevant as far as producing children is concerned. Because women, 20 years from now, I'm talking of 1971, it was saying 20 years from now, men will become irrelevant. Because the women will have so much to choose from. There will be sperm banks all over Cairo Road. There will be sperm banks. So girls will be going, women will be going to the shops and choose the sperm to get for fertilization. They will look at the age of the donor, how handsome he looks, like that. They will make choices. So me at the end of the lecture, I was worried. I remained behind. I said, the professor, are you sure we shall become irrelevant? He says, that's what I've told you. But it came in 1991, we were still relevant. Now we're still. So what I'm trying to say here, you become relevant if you maintain your health. Remember, Adam was created perfect. All the tubes, the epididymis, testes, they were all there, producing. And Eve also was given beautiful fallopian tube, the uterus. So the best is the natural way. If Adam and Eve, by the way, you know how Adam was excited, was alone and was given a woman, a lady there. And he said, God said, what? Says, she's a woman. Why do you mean she's wonderful? God was moving out. God, please, I want to give her a second name. What is the second name? Eve. What does it mean? She will be mother of humanity. Can we clap for Adam? So what did it mean? Eve body and Adam's body were perfect, and they had many children. So you people, the young generation, you still inherit very good body. But here, when you are presenting blocked fallopian tube, male infertility, epididymis is blocked. Now, in our environment, the worst infection you can get in this regard is gonococcal infection. It blocks both fallopian tube and epididymis. So avoid gonococcal infection. Keep your body healthy. When the time comes, I'm not saying today, don't do it today. I'm saying when the time comes, we are saying no sex before marriage. Wait until you graduate, get married, and you have a natural way so that the cost of this equipment we are talking about can be avoided. But in 1985 to 89, I worked in the urology clinic, and the problem is big. Families that come, women who do HST, fallopian tubes are blocked. Many, they have a problem, tubes are blocked, or testis has atrophied. Infections. Avoid these infections. So your job, and all of us, is to go to the society and say, please avoid genital urinary tract system infections. We should avoid also. Then our society will be getting healthier. But those who have the problem and they really suffer, the woman is approaching 40 years, no child. And you know, menopause will come in, they panic. So the advancement of this equipment we are presenting today is very, very important for those infertility problems that you will see in the clinics. So get ready to manage them. Let's develop. How I wish we can be planning for teams out of you people. Teamwork is the best. Can you see there's the embryologist there, there's the urologist there, gynecologist, obstetrics and gynecologist there, psychologist should be there. So it's the team. Out of you graduate, form these services. You can create a lot of employment out of yourselves because there's a great need there, great need. So please remain focused and concentrate on your studies. Work hard. Work hard. Don't be disturbed. Work hard and pass well. We want to see grades improving. Why only C, D plus? C? No. We want A plus, B plus, so that we know we have the future graduates who will look after God's people well. Be ready to learn from this professor. I want to encourage you. This presentation is good, and I hope in the future it will be repeated, Professor, because time has not been favoring us. We started at 13 hours. No, I was supposed to start at 12 hours. Thank you very much for your attention.
Excellent. Thank you, Professor. Now we have more questions in the chat. We have a hand from is this Mr. Elliott? Please, the floor is yours.
Thank you so much for that presentation, giving us quite a good overview. My comment, not just on the presentation, but just to look at also the ethical considerations. It's very important that when we have such these processes of assisted reproductive technology, legislations should also be in place, that they should also be in place at the right time. A big example that happened in the United States of Dr. Donald Klein between 1974 to 1987, somewhere there. The doctors started using his own semen to fertilize the ovum. And so in his clinic, he started over 90 children. And because there was no legislation, they could not prosecute him for that fraud he had done. And so the only thing that he paid for literally were civil cases. And so it's very important that as we adopt such technologies, legislation should be there. Thank you.
Excellent. Thank you. We have a question. This one is from Jay. Approximately at what temperature can you preserve the mentioned tissue?
Thank you very much for the question. For the temperature, we need to put the tissues at negative 196 degrees Celsius. The reason is for us to be able to stop all the biochemical reactions that can take place in the tissues or cells so that the cells cannot be degraded. Thank you very much.
Excellent. We have another one from Dr. Oria. How costly are these technologies to access? Can people in LMICs access them? Or are there programs funding that can bridge this gap?
Thank you for that question, Dr. Ria. To start with, the government of Zambia is very responsive in terms of its health process. They have health insurances for various classification of illness, and the government picks up a larger percentage of that. And so the cost, when the policy is driven by government, that is what we are advocating. We as a private university, as you know, we're just bringing out this to the knowledge of government so that policymakers that are within us will take it from here. And so when government, who has already realized the scourge of infertility in the country, I'm sure they are doing something about it. And as a private school, we are also at the vanguard of trying to woo other private investors. That was what they stated visitation from the leading IVF company in the world, Shivani, who visited us some time ago to see if we can partner and bring to our doorsteps most of these equipments that are seemingly very expensive if it is taken on a private basis. Thank you.
Thank you, Professor Obethe. Of which Dr. Oria, he equally gives his thanks. This is good to know. Please do not forget, this is still an open session, question and answer. The floor is open. We have a comment from a Mr. Patrick. He says it was a powerful presentation. If we do not have any questions, at least from the audience, once again, I would like to welcome back members of our professorial team. We have heard from Professor Lambert. Do we have other members of the professorial team with us? Do we have any other members of the professorial team with us? Also online?
Professor Mlenga was attending, and I wanted to add more for the sake of the student. When you talk of sperm, you talk of ova. Read in detail. When you will be going to the clinics, you will meet some of the challenges that I saw. You will find a couple camps. Some of them are blaming at the household level. A man will start blaming the wife and say, "You are the one, you are only giving me girls. I'm going to divorce you. Because I want a son and you are not giving me." You as a doctor should be able to explain what sperms are and what ova are. Ova carries 22 chromosomes plus one X chromosome, sex chromosome. That's all. You are entitled to that, women. But the men, freedom was given power to decide. I want a boy, I want a girl. That's a man. So the man has 22 chromosomes, like a woman, but she has the two types, X or Y. So when a man presents the sperm which is carrying Y, that will be a boy. You should be able to explain, especially after a grand round like this. If a man is bringing like X, like the lady has brought in the ova, it will be a girl. So 22 plus one sex chromosome, X, that's a woman, XY is a man. There are certain men who only produce Y. So wherever they go, the combination of the combination of ovum and the sperm content, it will be boys, 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 boys. We have met such families where now it's only boys, boys, boys. And then he says, but when are you going to give me a girl? It's wrong. It's not her. It's you, one. You are not giving her the X from you. So X and Y, don't forget that. Very important. Two, look at the distance from vaginal depositing vaginal area, the sperm. They must move to the fallopian tube. And these boys should not be lazy. They must move to the fallopian tube. The lady just releases near the fallopian tube there, and the ovum will be waiting. 30 million per ejaculation. 30 million. You can imagine the rush. The 30 million, one of them is going to Petra. The lucky one, isn't it? By grace of God, the lucky one jumps in. But it's the one who having X or Y. So have that imagination. You talked about ectopic pregnancy. Ectopic pregnancy, those who are poorly treated after gonococcal infection, there's a narrowing of the passage. So the sperm will pass, fertilization occurs, but the fertilized ovum, the zygote, the embryo there, to pass down to the uterus, it fails at the partially blocked fallopian. And then you have ectopic pregnancy. I wanted to really study and see what is important in relation to this grand plan. Because this is the way you want to stimulate your studying. You have to work hard, preclinical. How many hours are you sleeping? When I was your age that time, I was sleeping 4 hours because the competition in our university was very tough. 1972, they picked only 30 students from 600 applicants, and I was one of the 30. So it's very tough. But we want you to graduate with good marks. We are going to aim at the global market. So when you get your transcript, it must be comparable to Nigeria, to Kenya, to Uganda, Not to must see and the differences. Supplementary, What's up? You should be passing very well. We are learning so well. What can you do to pass well? So we are aiming at that as the Lusaka Apex Medical University. We want you to be very highly qualified, quality graduates. That's our prayer. And with these professors, I think we are going to reach that standard. We must continue improving every year until we get the best graduates out of Lusaka Apex Medical University. That's what we prayed for from the beginning. Thank you very much.
Wonderful. Thank you. Thank you, Professor Lambert. I don't see any of the members of the professorial team with us. That is fine. And we don't have any other questions in the chat. This looks like an invitation for closing remarks. I would like to invite a representative from our presenters team to with their closing remarks. Presenters, the floor is yours.
Good afternoon once more. On behalf of my team, I would like to say thank you to the professorial team in attendance, local and abroad. I would like to thank you, Professor Lambert and Dr. Kafumokachi, for the insightful information that has been given. I would also like to say thank you to my fellow presenters, for they have done a very wonderful job. It wasn't an easy presentation to prepare for. We had to meet at late over the moments with the weather, but we thank you that we have come through. We have grown not only as a team, but as individuals too. I would also like to say thank you to the moderators for providing us with the information that we needed for this presentation and for helping us with the research that we carried on. I would also like to say thank you to the audience for being involved throughout the presentation and for the information that was given and the good feedback that was given. I would also like to say thank you to the organizers and the IT department. It has been an honor and we are really grateful for you organizing this presentation for us and managing the information for us. With that said, I would like you to say all protocol be highly observed. Thank you.
Oh, well done, presenters. Please, another round of applause for yourselves. Those of us online won't hear it, but those of you in the room, please, a round of applause for yourselves. I'd now like to invite our moderators to give their closing remarks. Moderators, the floor is yours.
Thank you, Madam Sinondo, for always being there for us. I want to also use this opportunity to thank our dear professor, Professor Lambert, who is always very available. He's the one that has led to the success of all of what we are witnessing today. And in as much as he has always been there to encourage us, we are here to put in our best to make sure that we attain the height that is being expected of us. You can see from today's presentation, the students did very well. I was grateful. It actually shows that they took some time to look at their work, prepared it quickly, and came out to do all that they have been able to do. But from the beginning, we let them understand that they are engaged to the HIV. So they have to put in their best. If you stand here to speak rubbish or just do some careless mistakes, you are disgracing yourself before you. And we are not here to entertain those kind of lapses. So we encourage our students, even the ones that are here with us, who have not done the certificate today, they may be presenting some of them. So we are also learning from these experiences. For our participants out there, may I also use this opportunity to thank you very much for taking us some time to participate. We continue to employ you to always looking to our call, where we invite you to join us again. Next week, Tuesday, we start presenting again, and I think it's going to be an important topic, interesting topic, because we start looking at dementia and cognitive impairment. Is a topic that I think will be very physiological and be very interesting for people to learn about. Thank you, Madam Shinundu, once again. And then our technical team, Emmanuel Zulu, is always good. Once I see him in the hall, I get excited. I don't feel that thing from grace class. I think always been yes. As the presenters, it is typical because we continue using it subsequently. As we keep gathering the number of students who are doing well in the presentations, we continue to filter you again and again. You use the subsequent presentations as well. While we're mixing the new ones to make sure consolidate our efforts and the presentations here to satisfy both outsiders and the university. Thanks so much for the time you spent to get this work done. Madam Shinodo, please
I always like you to be there at all times, just like you have always done. We know the stress we put you through before the presentation in the hall. Thanks so much for always giving us your time to listen to the students, see what they can do before we showcase them. Thanks so much for being there. We'll see you again next week. Thank you very much.
Excellent. Thank you, Professor Etta. It is now my pleasure to invite Professor Lambert to give closing remarks from the professorial team.
Thank you very much. On behalf of the Vice Chancellor, Professor Ngeresani, who is also one of the founder members of this institution. You know, I think if you read about us, we're 8 of us, 7 men and 1 woman. And that woman, the mother of Shinondo here. Can you clap for her? So it is growing and growing stronger. I want to say thank you very much, professors. Thank you very much, the presenters. On behalf of the Vice Chancellor, we have started. And we want Mondays for pre-med, Tuesdays pre-clinic, Wednesday research programs, Thursday MPCHB students, your senior students. Friday they share nursing, physiotherapy, radiological sciences, they share Friday. So every day of the week, 12 to 14, those who are free, please remain tuned to this board here with Mr. Zulu and Madam Shinono. We want to make sure you practice how to present, even at international forum. The way you speak. I was just looking and said they are using broadcast area, the speech center. They are using the language area. When is language area? And your brain, you are using the brain very well. You reach all these stages, okay? Continue practicing how to present. Don't be shy. Speak with pride. The way you announce your presence and your presenting is very good. So let's maintain this quality. Encourage those who have not participated. Tell them how nice it is to present to the international forum. And I'm thanking the colleagues in Nigeria. Nigeria was getting closer and closer. East Africa, we are getting closer and closer. And I was very excited to see Dr. Elliot Tiwan. Can you clap for him? Our own very experienced anatomist. We want him to participate like he did. But I didn't see any gynecologist putting up their hand. I wish you had invited them. Maybe we did invite them. But in the future, topics which deal with things like this, we have full-time gynecologists, 2 of them. So we encourage them to participate. So whatever topic comes, I will ask Madam Chinondo. If it's urological, we should announce. If it's internal medicine, we should announce, especially Thursdays. Now watch us on Thursdays. If you are free between 12 and 14, because very soon you'll be going to clinical. You'll be the ones preparing these cases. Is that okay? So I thank you. I thank you, God, for this opportunity. Thank you very much.
Wonderful. Thank you. Thank you, Professor Lambert. We have now come to the end of today's virtual preclinical presentation. Once again, well done, presenters. Well done, moderators. Thank you, professorial team. And I would like to give a special thank you to those in attendance, especially those of you who asked your questions and those who took the time to be here during these presentations. You've done an excellent job. Your questions are proof of how attuned you are to these presentations. So for that, job well done, and thank you. Now, for those of you who are wondering about our presentations and where you could watch them, please follow the official Lusaka Apex Medical University YouTube page. You'll find everything there. Without any further ado, I would also like to remind our team of presenters, moderators, and professorial team that once this presentation is done, please do not go anywhere, as we will need a group photo. This is history in the making, so please do not forget to capture the moment. And with that, we have come to the end. Thank you for coming through. Enjoy the rest of your day. Remember, we have presentations Monday through Friday. Enjoy the rest of your day. Thank you.